We would like to start our program by inviting the head of school. We are Africans. When you come to a home, you do not feel welcome until the head of that home is saying welcome to you and tell you that you are in the right place and you are supposed to be here. But let me just introduce our head of school so that you may understand why this conference is and why this school, who's this person behind running this school. Professor Tobias Chirwa is an associate professor and the head of the school, the Wits School of Public Health. He is a program director for the Wellcome-funded SACAB, a sort of sub-Saharan African consortium for advanced biostatistics training. He is also a program director for the University of North Carolina and Wits D43 Fogarty Grant on AIDS implementation science and advanced cohort analysis together with a phase 1 WHO TDR implementation research. Now you understand why he is the school or the head of the school. Prior to this, he was the head of the division of epidemiology and biostatistics here at the School of Public Health and a research fellow in medical statistics in the London School of Hygiene and Tropical Medicine. Do you still want me to say more? As you can tell, he's a humble man. He doesn't like being elevated. That's the kind of head of school we have. As much as possible, he will run away from the limelight, but we're not going to give him that chance today. We're just going to complete this. Where was I? The head of biostatistics. Yes, okay. He has led post-grad capacity building initiatives, including the curriculum while at Wits, short courses in biostatistics, MSc programs in biostatistics, research data management, and SACAB training and research institution, and has raised over $17 million US. Take that in. As PI in the research and training grants. He has provided leadership to research and consultancy projects on STIs. Those are sexually transmitted infections, isn't it, Zui?
That's correct.
Thank you. And TB, which is?
Tuberculosis.
Thank you. And HIV.
Oh, human immunodeficiency virus.
I'm testing whether you got your medical degree or not. Disease surveillance, maternal and newborn health. He continues to work on TB diagnosis, treatment and adherence, and post-treatment survival. Child health, specifically low birth weight infants, and more recently malaria. His statistical interests are in longitudinal and survival data analysis. Let us welcome our head of school.
I didn't know when I was providing that you're going to read this. Yeah. But thank you so much for that welcome. Yeah. So, yeah, I think it's a daunting task, and I think when you look at the numbers, I think this has been by far one of the most attended conference that we've had. So I'm really amazed and dumbfounded. But I will go through the speech. Usually I don't prepare speech, I just speak. But considering the enormity of the task around and the people around, I thought maybe I should just jot a few points. So, all protocol observed, I would like to acknowledge the presence of the Vice Chancellors and representatives of the CARTA partner institutions. You're most welcome. And we have our northern partners also in the audience. I would also like to acknowledge the Science for Africa Foundation. I think they provide funding to CARTA, and one of the programs that she mentioned, SACAP, but we're not supposed to be in the limelight, but it's one of the programs that is also funded through Science for Africa Foundation, so we are grateful for that. And I saw representatives from FCDO, yeah, so I think they are also combined joint funders for the Deltas Africa program, so we did appreciate your presence. And other funding bodies who are present, the Dean's Office, Wits Faculty of Health Sciences. I really appreciate your support always, Professor Lindana Nguni. I think you're always here, and you'll see when he comes, he's very charming. So we are happy to have him from the Dean's Office. The National Department of Health, South Africa, thank you for coming and representing the department. And all stakeholders, including colleagues who have joined online. I would like to welcome you all to our first joint Wits School of Public Health Research Day and CARTA Conference. I think this partnership starts from a very long time when we are actually looking at the inception of CARTA. And the school has played a critical role in terms of initial curriculum development. I think things have changed now in terms of initial curriculum development, looking at having students registered for their PhD programs within the School of Public Health, or I should say Wits, and also running some of the joint advanced seminars that are run. I think there are 4 of them in the various institutions, but one of them is run at the Wits School of Public Health. And with the joint advanced seminars, we know that all the students who are registered in CARTA from various partner institutions, apart from those who are registered at Wits, actually come here and go through these particular seminars. And the school has been really instrumental in running some of these particular courses with the support from the northern partners of the CARTA scholarship, individuals, institutions as well. So for me, I think it is really a great honor that we have this jointly to showcase our research achievements for both the school and CARTA. It really cements our partnerships that we have had over a long period of time. It is my hope that this particular model that you've started, where you're looking at CARTA and institutional partners, will continue to other partner institutions, because I see that this is an equal partnership sort of relationship, and I think we should do the same to other partner institutions. So I'm grateful to CARTA leadership for actually having this particular joint conference. The theme of the Research Day is deepening public health footprint in Africa, building on successes and challenges. Because of that, we can't run away from research output being our major milestone for the school as well as for the CARTA program. And for us to have an impact on public health, capacity building, research and policy development in Africa, we need to be able to showcase these particular research outputs that we have. And from a school's point of view, we have outstanding research entities. We have Agincourt, Professor Steve Tolman, Professor Kathy Khan are here, Center for Health Policy, Nonsalsa Numero, I don't know whether she's here, but she's the director, and I see members of the unit are also here. Priceless, I also see members of the unit who are also here. And more recently, we have a research group which we are calling Gauteng Research Triangle. It's a research group, but it's quite big, but it involves UJ, Pretoria, UP, that is UJ is University of Johannesburg, University of Pretoria, and Wits. And it's an urban health and demographic surveillance site. And it's important to have that because it really provides comparative results with the rural demographic health surveillance sites that we have within the school, and it's run through the Agincourt research unit. Also within the school, we have research chairs on healthy workforce and equity for quality, and we have Professor Letitia Rispel here, who is the chair. And we also have another research chair, health policy and systems. I think we have Professor Jen Gouge, and Francis Griffith. Thank you. Yeah. So we have also seen a lot of research actually growing within the training programs. Usually when we say training programs, we also will concentrate on teaching and supervision, but beyond that, we have seen growth in the research for these particular training programs. So what we see is that over the years, the school has provided research leadership, and most of the work will be showcased through oral and poster presentations by students and staff during these 2 days. Having said that, research output is important, yes, but we must continue to think beyond publications by looking at the implications of our research for the larger community in the African region. Issues of social impact, engagement with policymakers, and development of policy briefs come to mind. And in the school, I think we have models of that in terms of Priceless, in terms of Center for Health Policy. They have been quite in the forefront, looking at engagement with the Department of Health, looking at development of policy briefs, and we continue to learn from them. So I think the point is, I think publications are good, but we need to think at what is the impact of those publications. Of course, we need them for promotion, but I think the more important thing is that how is that impacting on our communities? And the next point that I want to make is that more and more we're seeing research being driven within the African region. We are seeing a shift of the Center for Science Gravity. The vision needs to be enhanced and encouraging more donors and governments to be able to support such a model whereby we are promoting further multidisciplinary research, collaborative research through North-South and South-South approaches. I'm glad that we have a panel discussion on funding and hope the panelists will dig more into this as well. I also note from the program that we have exciting talks on multidisciplinary research, how research can inform practice, and the future of public health. We also have various plenary sessions on topical public health issues, and I look forward to hearing more on these and other presentations. It is my hope that the 2 days will provide an opportunity for us to interact, learn from each other, with potential collaborations emanating from such interactions. I'm truly grateful to the presenters, chairs of sessions, discussants, and invited guests for sparing time to be with us and take on these various responsibilities. The organizing and scientific committees have put together an excellent program, and we hope we will all enjoy this. Lastly, I just want to say, last night we were here trying to make sure that we prepare for this particular session. And the school administrative staff were here until late at night. The things that you see being displayed out there, the preparations that you see, that it looks good, I think they were here. So, and also including the audiovisual guys, I think they were here as well, making sure that we're ready for the day, for the 2 days. And I know we're just starting our conference, but I would like just us to show some appreciation for what they have done. So let's give a hand. So thank you so much. With those few remarks, I would like to ask that you enjoy the event, interact, and please share your knowledge with others. Thank you, Chair.
Thank you very much, Prof. Chirwa, for the warm welcome. For this Research Day and Conference, we actually received an overwhelming 326 abstracts, which were all reviewed. We accepted 80 for oral presentations and 54 for poster presentations. With that said, I'd now like to introduce our next speaker, Professor Lindelani Mguni. He's the Assistant Dean in the Teaching and Learning Office at the Faculty of Health Sciences. Associate Professor Lindelani Mguni, he's the Deputy Dean in the Faculty of Health Sciences from the University of the Witwatersrand and a Research Fellow at the University of South Africa. Lindelani is a C2 NRF rated researcher in biology education with a special interest in curriculum and instructional design and development. He's a recipient of the Principal's Award for Excellence in Research from UNISA. He's also received the Dean's Award for Excellence in Young Doctoral Scholarship from the University of Pretoria. He's also received the award for the most methodological, innovative research presentation at the Research Indaba from the University of Pretoria. He obtained his PhD in Curriculum and Instructional Design and Development from the University of Pretoria, a Master of Science in Biochemistry, cum laude, BSc Honours in Genetics, and a BSc in Biochemistry and Genetics from the University of KwaZulu-Natal. Lindelani has 15 years' experience in higher education, having worked as a lecturer at the University of Pretoria, a senior lecturer at the University of Johannesburg and Witwatersrand, and an associate professor at UNISA and University of the Witwatersrand in life and health sciences education. He has supervised several masters and doctoral students to completion. We welcome you, Prof.
We have a problem. And the problem is that now I need to charm you. And I didn't plan to charm you, but the head of school said I must charm you. So, and I don't have my charm today. Sanbonang. Good morning. Sanbonang. Dumelang. Goeiemorgen. Eta. Colleagues, thank you for the invitation. I was sitting next to my colleague there, blushing. I am relatively shy, even if I don't confess it and I don't show it, I'm relatively shy. So please do pardon me if I don't look at you and I look down here. It's because you look too nice, I'm scared. It is Heritage Month, and I must apologize up front because it's Heritage Month, and I come from KwaZulu-Natal. I'm Zulu, and by tradition, I was supposed to wear my traditional attire this morning. I did put it on. You don't believe me. I did put it on, I tried it, but it was just too cold. So I'm hoping that on the 22nd it's going to be a bit better so I can wear it and come better prepared. But on a serious note, colleagues, good morning. I may just start by sending kind greetings from the Dean of the Faculty, Professor Shabi Madi. Unfortunately, he's had to attend the senior executive team's retreat this morning and tomorrow, unfortunately. So all the senior staff members of the university, the senior most, unfortunately, none of them are available for these 2 days because of that engagement. I must greet our head of school, Prof. Chirwa, and thank you for the kind words that you did mention, as well as our guests, particularly the vice chancellors and other colleagues who've traveled across the continent to join us these 2 days. We really appreciate you coming through. CARTA Director, good morning. Colleagues from the Department of Health and other government institutions, greetings to you. Plenary speakers, members of the community in the faculty and elsewhere, and all the guests, greetings to you. I have and it's because of an experience I had when I was at a conference in Portugal. As you would know, to convert our rand to euros is rather a very painful experience. So I attended the conference and I presented a paper which was well received by colleagues in the audience. But after presenting the paper, I had a moment of reflection as I was walking through Braga, the city in Portugal. And my reflection was, one question: was it worth it? Was it worth traveling to Portugal to present at the conference? And I reflected on this question. Of course, I looked at the money that was spent by my government, ultimately, sending me there, obviously through the NRF funding and the university and me going there. But the question remained, Lindelani, was it worth it? You presented for 20 minutes and you had interaction with colleagues, you've done networking and all of that, but the question remained, was it worth it? And as part of that question, I then reflected on an important, perhaps more important question, and that is, what is the function of academia? We've got professors, we've got doctoral students, we've got all of this community, but what is the function of this community? What do we do? And this is an important question for me in the context of Africa in particular, where we've got a lot of challenges, socio-economic, political, environmental, and so on. And the question that I keep asking is, what is our contribution as academics in this problem? Do we offer solutions, or do we perpetuate the problem? Of course, it's a question that I cannot answer for everybody, but I can answer for myself. But it's a question I asked, what is the function of academia in society? And what often happens is that universities become these big towers that are not even accessible by the ordinary community, so they can't even come and interact with us because we are academics and we come to these conferences as academics, but members of the public who need to hear what we have to say, or even politicians, are not invited. So what is then the function of academia? Now, there are three fundamental functions. One, we generate knowledge. Two, we teach that knowledge to prepare the next generation of academics. And then three, we must engage the community in addressing some of their major challenges. Now, in the context of public health, and the question that I want to ask everybody who is here, particularly those who will be presenting and those who will be listening, the panels and everybody, the question I want to ask is this: to what extent are we addressing the urgent need of society? Because it's great to publish papers, 100 of them per year, or whatever number that you can publish. It's also great to produce PhD students. It's also great to get research funding. But are people benefiting from what we do? Ordinary people. And that's the question I would like to ask. Now, within the context of public health, of course, in line with this conference, there are some urgent ideas and problems that have been identified that we need to address. And I just want to highlight some of these, and then I'll ask a question at the end. So, for example, we need to address issues related to occupational and environmental health. We can look at this from a very academic perspective and read literature and then leave it at that and live within that academic world. But we do know, you and I, that our communities out there, including South Africa, are exposed to some of the most poisonous chemicals and products that the world has ever seen. We research about them, we publish about them, and then it ends there. My question then is that enough? Are we fostering enough awareness to facilitate a shift towards healthier practices by ordinary people, by governments, by companies, or whoever else need to do it? Related to that, we just come out of the COVID-19 pandemic, but what about industrial epidemics? Are we doing enough to shift commercial interests to be a little bit more friendlier to ordinary people? And this pains me because I think it was 2019, I was at home in KZN, and it was a celebration. So a family member had bought this 2-liter Coke from a nearby shop. So they brought it into the house, but when they opened it, it was just silent. You know that sound that it should give? This one didn't give that. Needless to say, I said, you can't drink that. But what if I was not there? What poisons do ordinary people drink? I'm not saying Coke is okay necessarily, but I'm just saying it can even get worse because we don't even know who's putting these products together. So are we doing enough to educate our people about what they consume and what they're exposed to? In addition to that, another question that we need to ask is on communicable and non-communicable diseases. And unfortunately, what happens with humans is that we tend to move by waves. We get excited at a moment because there is a wave of something, and then we're excited about it, and then another wave comes. You know, if you're in South Africa, you know the music that young people dance to, and every year, every week there is a song. Currently, there's a song that says "Ngilale Hotela what" that they are dancing to. A few weeks ago, it was another song, and then there's always these waves. And what has happened, just from my observation, is that we've forgotten the seriousness of HIV/AIDS because we've shifted our mind to think about COVID. But I promise you, in the next year, we'll also forget about COVID and move on to the next thing. And as a faculty, just observing, there is a particular move as well into a particular direction. But my question is, are we doing enough, or have we solved the problems of yesterday now that we are chasing today's problems? Now, we also need to think about another issue. The government in South Africa has just, processed documents related to the NHI, which is an important question as well. But another question related to that says, what is our contribution in ensuring that we reimagine, strengthen health systems so that they can be a little bit more resilient to current and future burdens? Now, when I say that, the instant response is that that's not my problem, I'm just an academic. So somebody else, maybe in government, must attend to these health systems. And this does not, by the way, just talk about the hospitals and the infrastructure-related issues. It does also include human resources, finances, and so on and so on. The question that I want to ask you is this. If not us, then who? Now, to become a president of a country, particularly in these democracies, you don't necessarily need a formal qualification, in any particular field. I believe that maybe Prof. Chiro can be a president tomorrow, but my uncle at home also can be a president, and so on. So some of these colleagues are not aware or educated on the urgent matters that are affecting their people. And that's a political question, and I don't want to get into it. The part that I want to get to is, when we recognize that, what do we do to assist? Gauteng, Johannesburg is going through, and Pretoria, I don't even know who the mayor of Pretoria is at the moment I stay there, but I always ask myself, what is my role in improving the lives of the people in Pretoria where I stay? Now, as public health specialist, I therefore ask you the question, what are you contributing in strengthening the health system in Africa? Lastly, the wave I've just spoken about was COVID. There is a wave that we are riding at the moment, and we are just about to get off it. It's just about to, we will get off it just now, I promise you. And that is the ChatGPT wave. We are about to get off it, but we're riding it. And ultimately, it relates to artificial intelligence and all these technologies that come up. One of my worries about us, maybe as a university and perhaps even the people of Africa, is that we get left behind. The question that I want to ask you then is this: how could we leverage these technologies to enhance the health of our people? What can we do to leverage these technologies, be it machine learning, be it data science, whatever it is, but what can we do to leverage them just so that the lives of our people are a little bit better? Now I've highlighted at least 5 fundamental points and issues. The question then is this. I said I'll ask the question towards the end. As scholars from the continent of Africa and the world, of course, but also as a community of a university, be it Wits University, Pretoria University, whatever other university, but as a community of that university, And perhaps let me stop at faculty and say, what are we doing to improve the lives of our people? But I'll leave it at that and come a little bit further and say, as a school that you belong to, no, let's leave the school, as a department, because the school is made up of departments. As a department, no, maybe let me leave the department and move a bit closer. As an individual, because Wits University is a collection of people. As individuals sitting in this room presenting today, my question to you is this: to what extent are you achieving goals related to the urgent public health challenges? I don't know how to answer that question because I don't know how we assess the impact of what we do. But I'm hoping that as you do your presentation over the next 2 days, you will reflect on this. But I also hope that when you apply for the next research funding or when you attend another conference, you think about these questions and say to yourself, now that I've traveled to public health, now that I've traveled to South Africa, now that I've traveled to Portugal, is it worth it? With those few words, colleagues, I wish you a successful conference. I think I'm speaking on behalf of the Dean when I say this is one of the most productive schools, not just in the faculty, but in the university. And we are blessed to have some of the greatest minds in this school. And I'm sure the interactions are going to be beautiful, productive, informative, but most importantly, they're going to be impactful. Thank you very much, colleagues.
Food for thought. I'm filling my heart with all the questions and the challenges. You've humbled us. You are challenging us. If we are public health people, where are we with preventing the diseases that are not supposed, that are preventable?
Exactly.
So thank you for making us think. Sure, I'm kind of like touched. I would like to introduce our next speaker. We have packed amazing speakers, as you can tell. So I've read this bio for Dr. Catherine Kyobutungwi, but I could not find what I heard yesterday when somebody was introducing her in another, forum. Mm-hmm. That person described the most amazing. Those words are not here, are not part of the words I'm going to read. I suspect she wrote this, what she gave us. And the person, it's because she knew her. That's why she could elaborate. But I will just take what she had. She is the executive director. Take it in, of APHRC. This is #1 organization in Africa. Yes, okay. APHRC, it stands for African Population and Health Research Center. She's also the co-director of CARTA because CARTA is housed in the APHRC. She previously served as the center's director of research and head of the research unit on health and systems for health. Catherine has a medical background and is a trained epidemiologist with research interests in the interface between non-communicable diseases and health system strengthening. She has led research projects on epidemiology of NCD risk factors in Kenya and designed and tested service delivery models for resource-constrained settings such as slum settings. She has also conducted research on the policy context for NCD prevention in several African countries. She is a Jup Lange chair at the University of Amsterdam and is working on chronic disease management as an entry point to make healthcare systems more responsive to NCDs in Africa. She is a fellow of the African Academy of Sciences and the co-editor-in-chief of PLOS Global Public Health Journal. She has published, take this in, more than 150 peer-reviewed papers and sits in multiple national and global expert advisory panels. So please help me welcome her.
Thank you very much, Daphne, and thanks everyone for being here. I was saying that I'm protocol-less, so all protocols observed. I have to remember that, because I'll sit down and say I didn't welcome all of you and the amazing guests you've had over the last 2 days in the meeting that we've had. And this is a culmination of many hours and months of preparation. And on behalf of the CARTA community, I'm really pleased to be here to see a full auditorium and to be in this energy that I was seeing on the bus and at the registration. So Professor Lindelani, when he sat down, I said, if I had time, I would have written my speech, but I didn't have time. I was coming right after him because he touched a lot on the things I wanted to say. And I'll start with a story. And this is actually a true story, so I might cry, but maybe not. It's actually a true story. I think most of you have WhatsApp groups in your family, your alumni, your work. So we do have a family WhatsApp group. And on April 24th, my father, who is 84 years old, posted a forwarded message which says, Rose has died. And the first question was, who is Rose? It was a forwarded message. So the first question was, who is Rose? And then he said, Rose is John's wife. And the second question was, who is John? And then he wrote and said, Rose is so-and-so's grandson. That so-and-so is my cousin. And I'll call him James. So Rose was the wife of my cousin's grandson. Okay, I'll not tell you my age. But James is a few years older than me. Just a few, maybe 10 at most. But James had a grandson whose wife had just died. Now, James's mom is my dad's sister, by about 15 years younger than my dad. So you can start adding up. You can start adding up. So after understanding who Jane was, Rose was, the question was, what happened? And I think it's common. When you get news about a death, you want to know what happened. And what happened took me back to a time when I was doing my master's in community health. We used to do an exercise of why did X die? And then there were these write-ups, I'm sure some of you have encountered them. Why did X die? This time it was, why did Rose die? And after many WhatsApp messages and phone calls, the story emerged of what happened to Rose. So Rose was a teenage wife, 17 years old, of John. She was about 5 months pregnant. And a few weeks before, had had a fever. And it's a true story, I'm telling you. And then she suddenly noticed that the baby was no longer kicking. She had already attended antenatal care, so she went back to check. And indeed, they confirmed that there was no fetal heart and asked her to go to a hospital. Now, I've been to my auntie's place, and we used to joke when we were growing up that it's where roads end. Have you ever seen a road ending? Yeah. You drive, it doesn't matter where you come from, the road ends, and there's a small little roundabout, and then you go back. The road ends there. And from there, you walk, but there's no road. But that was then. Now the roads are better, so you can get a boda motorcycle, taxis of some kind. you can do something and get a car. So they mobilized resources and ended up at the nearest hospital, which happened to be a mission hospital. After examining her, she was told that she needs to deposit a sum of money before she could be hospitalized. For the Ugandans in the room, it was 650,000 Ugandan shillings. It is 177 US dollars equivalent. John mobilized all his networks, and they could not raise $177. So the money they raised, they decided they're going to go to the nearest regional referral hospital, which is about 45 kilometers from the mission hospital. And they got there. And Rose was hospitalized. And 24 hours later, she went into labor. The medics in the room will know probably what happened. But Rose bled to death. In the regional referral hospital, about 24 hours after admission, having moved from mission hospital and the health facility that referred her. So I go back to those exercises of why did Rose die? And we used to ask ourselves, what if the regional referral hospital had all the tools and resources that were required to give Rose the attention she required? But you can also go back. What if John had $177? She would have stayed in a mission hospital, which perhaps, hopefully, had the resources to manage her care. But you can also go further. Why was Rose pregnant at 17? Why was Rose married at 17? Why was Rose not in school, studying to be a teacher, or, I don't know, a nurse, or a banker? We can go back. We can keep going back, and you can go back and find, why is my 50-something-year-old cousin having grandchildren who are married? That's another, we can go back. So there are many whys of why Rose died. And many times, when you think about where we sit, maybe we see the absence of fresh blood and whatever other things were supposed to be done to save Rose's life. But there are many other factors that happen. And therefore, my topic was building a vibrant, multidisciplinary African academy that leads world-class research. And I tried to pick out keywords, and everything was a keyword. Vibrant, multidisciplinary, African academy leads world-class research. So I asked myself, why do I focus? Because potentially I could talk about each of them, but I only have 15 minutes. So I asked myself, what is world-class research? What is vibrant? What is vibrant about us? What is vibrant about the African Academy? Why is it necessary to have this kind of academy? And on reflection, I said, okay, because we need to solve complex problems. Rose's problem is complex. And perhaps it's not enough to have the right medicine, or the right antidote, or the right tools at the health facility. There are many things which have happened in Rose's trajectory. She probably did not stand a chance. Even when with the best equipped facilities, perhaps she did not. Because we need to solve complex problems, and we cannot solve those problems alone. And therefore, as young academics who are in this auditorium, we need skills to be great scientists, to be great researchers. We need skills to do all the wonderful work that Prof. alluded to, but we need other skills. We need skills to network. We need skills to listen. We need skills to listen to the people who could have kept Rose in school. We need skills to listen to the people who could have done other things that influenced Rose's trajectory. We need to learn and unlearn. We are learning now. At some point, we need to unlearn, throw out everything, and look at the world from a different perspective. I'm not saying build the road. I'm not saying keep Rose in school, but recognize that there's somebody whose responsibility it is, and therefore, from where you sit, how do we all come together so that people like Rose and millions like how the African continent actually stand a chance. We need to understand and work within a world where health is a result of many interconnected systems. And I think that's what Prof was referring to. Rose's story is part of a bigger picture. I mean, most of you are familiar with the statistics. There are some statistics which have stuck in my head, and I think over the last few months I've been talking about the statistics. Africa's current population is about 1.35 billion people, 1.435 billion people. And there are projections which show that by 2050, we'll have added about 1 billion more Africans. So we'll be at 2.4 billion. By the end of the century, most of us probably won't be there, but our kids, grandkids, they'll probably be there. Africa will be about 4.2 billion. So it will have almost tripled its current population. Now think about that. Think about your village, think about your university, think about your town, the estate you live in. Multiply by 3 people. This university, how much space will you need to accommodate? 3 times more students. How many more universities do we need? How many more schools? How many healthcare facilities? How many roads? How are we going to produce food for this population? So when you talk about a vibrant African academy, those are the questions I ask myself. What is vibrant about us? Is it in our passion to strive for meaningful change? Is that the vibrancy? Is it in our quest for partnerships with government, with society, with our communities, with the media? Is that the vibrance? Is that what describes us as vibrant? Is it in our vision for an Africa where Rose and millions like her stand a chance at life? What is a vibrant African academy, and what is world-class research? So I'm supposed to talk about how to build this vibrant academy. And I think from our experience, from where we sit, I think we need to rethink everything. How we teach, how we train, what we teach, but most importantly, what is our place in this system where people like Rose and others like her don't stand a chance? What is our place? And I think that's where Professor Lindelani was taking us. What is our place in this system? Recently, where's Prof. Barnabas? Okay, I think he's out. He's the VC of Makerere University, where I studied. And he said, it's a statistic which most of you know, that Africa, according to World Bank report, needs 100,000 PhDs over the next 10 years. 100,000. At first I thought, like, that doesn't sound like much. 10,000 per year doesn't sound like much. But apparently, Africa produces about 2,000 PhDs per year. The whole continent, 2,000. But my problem with that statistic is, PhD for what? Is it 10,000 PhD per year and we tick a box? Or is it PhDs that are vibrant, according to the remarks I've just made? So our place in the world, as CARTA, we are focused on PhD holders that are research leaders. If you're a CARTA fellow, if you're a CARTA graduate, we see you as a research leader. We want you to be a research leader. Maybe you don't recognize it. Now I'm telling you, if you're here. We are looking for research leaders. We're looking for change agents within our academic spaces that are going to be those solution givers and solution providers and the partnership builders and the bridge builders and the people who appreciate the world for what it is, that our narrow focus is just one little piece in a big puzzle, and we need to figure out how to bring all the pieces together. So we need to rethink how we train. That's the first thing. But we also need to think about what kind of environments our academics train, work, and grow in. There's computers, space. If you're in South Africa, you need standby generators, that's hardware. But there's the software. And in my view, the software does not need Marcus, does not need NOSA, does not need Alphonsus. The software of our enabling environments does not need funders. There's a recent report that came out, a culture. People enter academia and leave broken, traumatized for life. So even as we think about 10,000 PhDs per year, we need to think about the fact that they need to be functional, well-adjusted human beings before we can aspire for change. Because traumatized people cannot be the change agents we're looking for. And my appeal is that even as we strive for the hardware, there are things within our power of creating that vibrancy. We can't have vibrant people when they are traumatized and broken human beings. And that is within our power to change. So back to today, this is a great event. It's something which is extremely important if you're an academic in your life. At the beginning of your career, you've not finished your studies, you have just finished your studies. It's an extremely important event, but my challenge is that it's not an end. It should be seen as part of a bigger journey, maybe a much more difficult journey. This is easy to come here and present your work. That is the easy part. And therefore, we have to start seeing as research as a piece in a bigger puzzle, and that research is not an end in itself, and that our skills and expertise are not sufficient to answer questions which are of interest only to us. I was just on the last page. I was just concluding, and now I'm wondering whether I should rewind a little bit. But clearly, Wits has a standby generator. I was told that sometimes it doesn't kick in, and somebody has to give it a little shake. So that's what happened this time. You need a little shake to get started. So I was concluding actually and saying that this is a piece in a journey, and we have to question ourselves about what's our place in society. And Professor Lindlani asked the question of, if not us, then who? If not now, then when? And I'll add on to that and say that we are the leaders we've been waiting for. Wherever you are, if you're here, you're a leader. And that's the thing. What are you leading? How can you lead? What is within your power to lead? And it doesn't matter what it is. There's no other leader somewhere that's going to come and solve the problems that we face as a continent. And that's my challenge to you, that as we think about our place in the world, we have to ask those things that are within our power to lead and then lead. I thank you very much for the opportunity and wish you a very productive 2 days. I'm looking forward to interact and learn about your work and maybe connect and partner in how we can move the continent forward for Rose and many like her. Thank you very much.
Thank you, Dr. Catherine, especially for that reminder that we are actually the ones we've been waiting for. The story of Rose is one that happens too many times in many health systems on our continent, and we are the ones that have to be making the change. With that said, we're now going to introduce our next speaker.
Our next speaker is Professor Nicholas Crisp, and the name is well known to most South Africans and beyond. Professor Crisp is a medical doctor and public health medicine specialist, an honorary professor in public health medicine at University of Pretoria. He was Superintendent General, a head of Department of Health and Welfare in Limpopo. Limpopo is one of our northern provinces, where he served from 1995. As you may remember, 1995 is a very special year in South Africa, where we got our democracy. He served from 1995 to 1999. Prof. Crisp was then a self-employed consultant and has worked on projects in several African countries, including South Africa, Nigeria, Ghana, Lesotho, Botswana, Namibia, and Tanzania. In 2009, he served as a special advisor to Minister Barbara Hogan. He was intimately involved in the establishment of the National Health Laboratory Services, the transfer of the medico-legal mortuaries from police to health, and the creation of Forensic Pathology Service, and in the establishment of the South African Health Products Regulatory Authority, SAPRA. He is now employed as the Deputy Director General, National Health Insurance in South Africa government. And like everyone else, was diverted to support the COVID-19 response for a while. But recently, I would like you to all help me congratulate him. He's just recently been awarded the Public Health Innovation and Lifetime Achievement Awards.
Okay.
Morning, everybody, and thank you very much for having me, and thank you for the introduction. I want to start by saying Rose should never have died. Rose should never have died, especially not at 17. It's not actually what I'm supposed to talk about because I'm doing something different, but I normally also don't prepare and I prefer to just talk. But today I'm a little bit out of my depth, so I'm going to be speaking using a few slides because I'm talking about something slightly different from what I normally do. Normally I'm banging on about NHI and why we have to have a system for universal health coverage. But let's talk a little bit about research practice relationships and how we get these hundreds and thousands of PhDs and all the work that is done to actually make a difference to the people who use the health services. And we deliberately don't talk about patients because a lot of what we do, we want to prevent people from being patients. We want them to be users of the health system and interacting with what we do so that they never end up having to be a patient, or if they do, it was completely unavoidable. So why are we interested in the research informing practice? Well, because the world around us is largely still unknown. We think we know a lot about it. But I've never learned so much in my life during COVID as in that short space of time. I thought I'd learned a hang of a lot, and I thought I'd learned a lot by the time I left here. When I did my M.Ed at Wits in the School of Public Health, I left here in 91. I thought, yes, now I'm ready for the big wide world. Then you find things that happen to you, and you learn that the world changes a lot. Doing research for the sake of research, as we've heard. And much of it is esoteric, and it doesn't always contribute meaningfully to the way in which we practice. Might be exciting. That's not to say that the little gems that come out of esoteric research don't add up at some point in a linear chain into something very dramatic and end up with a Nobel Prize. Likewise, continuing practices that have not been researched, and I'll show you a slide in a moment about what bothers us within the health department, and not having the evidence of what we do is also not helping us to provide better health care. So the question is really how we bring research findings, publications, qualifications, and so on into practice. So there's an abundance of research that's available. But we all know it doesn't translate into anything unless you actually steer it. And what we do have is we have this gap between the healthcare and the patients, what they receive in practice, and what is being recommended. So even really good research that is done, even very practical, implementable work that is researched and published, often doesn't translate into changes in practice. Then that means the patients fail to receive the best possible treatment and the best care available, and health organizations and society miss out on the potential value of all of this research. So the challenge lies in translating this clinical knowledge, and when I say clinical, I see clinical in a far wider spectrum than what a doctor might do. But all this knowledge, we need to promote the exchange, transfer, diffusion, dissemination of evidence-based knowledge to practitioners and decision makers. So where I sit, whether I'm currently sitting in an administrative position or where I worked before when I was very much involved in the field and in vaccinations and so on, if that evidence-based knowledge is not transferred to the practitioners, we continue using the old ways of doing things, we're not improving health. We need to support professionals that they actually use this new knowledge. So during COVID, it was very frustrating for me to discover that we were developing clinical guidelines for caring for COVID patients. And I don't know if you can all remember what it was like then. We knew nothing. We were intubating and pumping people with oxygen and ventilating them. Then we were nursing them upside down. Then it was this. And then we wanted to inject detergent. And then we wanted other things. Do you remember? We knew little. But there were clinicians in the world networking and drafting clinical guidelines. In my role, I was busy trying to get beds for patients who needed to be admitted. And I was trying to get the public and the private sectors to work together. And it was terrible for me to find that there was a different clinical profile in the private sector and protocol than in the public sector. Because the public sector had less money, you can't put the patient in the ICU, but the clinical guideline didn't say you had to be in an ICU, but you did have to be in the private sector. So why was there a different clinical protocol developed from the same research, from the same evidence base for people who had money and people who didn't have money? Very frustrating time for me. We need to facilitate this interplay between the individuals, the new knowledge, and the actual context in which this evidence is being operationalized and used in daily practice. Otherwise, it remains in the journal that we were hearing about. It remains in somebody's library. And making sure that the applicability of the research results are locally evaluated. So that's what we do in SAPRA as well. We know that medicines are registered. They've gone through a whole process before they're registered somewhere in the world. But by the time we use them here, we need to make sure that they are appropriate and safe and applicable to our environment, even if we don't include them in our clinical protocols, which is another story. So many of the improvements that we see in chronic illness care management, actually, they co-evolved. They weren't even as a result necessarily of deliberate research. They were things that people observe and they assimilate rather than some proper structured organizational change. So it's not only the research that contributes, it's other things that happen in practice that make a difference, like the end of the road. What do you do at the end of the road compared with at the beginning of the road? Much of this change that happens is attributed to leadership. Somebody stands up and said, I'm going to bat for people with HIV. And they push it and they make sure that we move in a direction, and TB and cholera and whatever the case might be. But you have to have more than just that leadership. You have to make sure that everyone, the nurses in the wards, the junior clinicians, and everybody assimilate that new practice. Otherwise, it just remains something that somebody researched and you got your PhD for it or your MMed or whatever for the work you did. So we need to find systematic ways of making sure that the research findings that show the evidence for the change and the improvement that we do find their way into practice. Now, people don't like change. I spend my life all day, every day. You've probably heard me on the TV and radio already 2 or 3 times today. And tonight, not that I'm advertising for the TV, it'll be a whole hour. Between 8 and 9, I've got to defend vaccines and the purchase of vaccines in COVID. I'm still in court weekly because people are saying we killed people by giving them this poison that we said was a COVID vaccine and so on. Yeah, this is years later. People don't like change, and people have a fixed idea, and they don't read the science, and they don't understand the p-values and what this graph says and that graph says. And in clinical medicine, and I would venture to say beyond clinical medicine into public health, people believe in their autonomy. Individuals, nurses, doctors, everybody, don't really like change. Even when the decisions that are reached through clinical research and consensus are very clear, people still don't like change. And they defend it by talking about their professional identity, their right to act independently, without instructions from others. And this is my biggest headache in COVID. We're going to leave. We're going. I don't know where we're going, but we're going. Because you're going to take away my autonomy. medical scheme already stopped your autonomy 20 years ago by telling you what you're allowed to prescribe and not prescribe and which patients may and may not do whatever. What's your whinge now? So this clinical autonomy is necessary. That's the point. Because when you treat a person, when you work with a person, and for us in public health medicine, when we work in a community, every community is different. Every person is different. So although we learn from the whole and we get the PhD results and we convert it into practice and we publish it as policy and we convert it into whatever we are going to do, it's still got to be translated into my care. And that's one of my problems that in the job I do at the moment, is trying to do away with the vertical and siloed mentality that we have. We treat HIV. No, we treat a person with HIV. And that person happens to be pregnant with diabetes. Now what? No, my data's in this model and in that model, and I get my thing. We have to move away from that, and we've got to take and recognize the clinical autonomy, but at the same time, tell the person, listen, times have changed. Have you heard of dolutegravir? Wow! You know what I mean? So, the mere dissemination of evidence-based decisions, clinical guidelines, whatever we do, will not affect the behavior or the change of people. Just because we send it out, we publish it, nice glossy thing comes out from the Department of Health, goes on the website, doesn't mean any clinician will change. Well, ultimately they may have to change if it's a different medicine, of course, because you won't be buying the old one anymore, but there are complex reasons for non-compliance, and we need to understand what those complex reasons are, and we have to have continuous involvement of all the staff in assimilating whatever changes there are in the way that we look after the people we are charged to look after. We need to create new guidelines and creating new guidelines and relying on mandatory guidelines, which is the way we tend to do it, will not change the behavior of practitioners on its own. We have to have a different way of doing things. If I send an email, if I send, come and stand and give a lecture, or whatever I do, and I believe suddenly that the practitioners are going to change their practice, I'm dreaming. There's a better chance of a drug company running a seminar and giving you a pen will change your practice than me doing it the right way. So this is how it used to work. And in many places it still works like this. We call it gobsat. Eh? Good old boys sat around the table, they prodded the patient, they bled them. I can never understand why you bleed someone when they've had trauma, to see if you could improve the... But anyway, they did that, and they made the decisions. And for those of us who are old enough, this is how it worked. You went on the 6 a.m. ward round on Saturday mornings, in my case in Groote Schuur Hospital, and the professor knew everything. That was it. Then we moved to evidence-based medicine and this hierarchy through getting case studies, case control studies, cohort studies, etc. And we have evidence-based medicine. Now we're shifting and we're saying, yeah, well, there's evidence-based medicine, but there's this thing called health technology assessment, where we really try to understand how, whatever it is, a technology could be a medicine, it could be a procedure, it could be whatever, influences and feeds into evidence-based medicine. So our knowledge and our ability to triangulate all of these new inputs is fantastic, but how do we convert it into practice? So one of the ways, and I don't profess to be very knowledgeable about this, but I had to do some reading for today. So I would like the concept of research practice partnerships. And reading a little bit about it, we'll obviously continue to have challenges for a long time. But we do need to interact more. And just this week, I was asked, so what are your main research needs in NHI? So that we can, you know, that the University of Pretoria has kindly given me this title, but what it means is I get all the registrars to rotate through my office for 6 months now. Some of them are sitting in the audience here and they can tell you they get work to do. And so we try to interact in a way that you learn what it's like in practice, and you are able to bring, hopefully they're smart enough to say to me, yeah, but Prof, we don't do it like that anymore, you know, that was 1985. But, so that interaction is really important. We need to bridge this gap between research and practice, and it will remain a challenge unless we proactively find ways to do it and take the time to do it. And then integrate the research into this clinical decision making, and in our case, public health. So in the education literature I was looking at, they talk about instrumental use of research, where the research is used to directly influence a decision. They talk about conceptual use, where the research is influencing a person or organization by challenging and supporting the existing ideas and extending their perspective. They talk about symbolic or political use. I guess I play in that space a lot more than I ever used to. And then process use, which is what we used to do in the field when I was still spending most of my time in the field, trying to say, how do you... I know about vaccinology, I know about immunology, I know about vaccines, but I know nothing about cold chains and cold chain maintenance and how to get the vaccine into 600 children every day if I'm going to prevent neonatal tetanus and measles. So simply packaging and posting research is unlikely in itself to have a significant impact on decision making and behavior. Just by the fact you published it and sent me a copy of your Lancet article did not make any difference. First of all, I only read the abstract because I don't understand the numbers anymore. And if you didn't make it clear in the abstract what you wanted out of it and then come and make an appointment in the office to influence the appropriate decision maker, nothing's going to change. So behaviors that are necessary for these approaches have an impact, including opportunities to engage with the interventions, motivation to do so, and the skills and capabilities to understand the use of the impacts. Otherwise, it's not going to change. Interventions that create access to research, that's what we actually need to do. They only appear to impact decision making. You know, we all have a seminar and we all go home, that's it. We need to build people's skills to use this evidence. So I'm ending now with, there are 3 key lessons, I think, and this was stolen from, this is what I do, I steal from other people's thoughts when I don't know the subject very well. But this guy called Jonathan Sharples, who writes in the education literature, talks about traditional communication and dissemination of research being seen as just the foundation. You've got to move way beyond that. And that's where you start to work with us, translational and adoption mechanisms, and then general capacity and skills to use that research in the sector will require a lot more work. So we need to consider how we choose between these different ways of using research in these research practice partnerships. We need to work out how to include practitioners more in the generation of research evidence. We need to build effective partnerships, and not short-term. They have to be long-term. They must focus on addressing problems of practice. They must be mutual. If they're just for you to get your PhD and I get nothing out of it as the department, I lose interest in you quickly, and vice versa. They have intentional strategies to foster partnerships and relationships, and they produce original analysis. It may be useful to experiment a bit more with this, and I'm inviting you, certainly those who work in public health medicine, to send your registrars, yourselves get involved. There's some of you at the back, in the middle, and on the sides who I interact with quite a lot. Thank you for that. That's what we need, and to make sure that you are able to do the research we don't have time to do, but make sure that it's practical and we work together to translate it into action. Thank you.
Thank you, Prof. Chris, you have your first registrar knocking on your door already. Thank you. Yes, we are beginning to pick up a theme where we are being challenged as researchers, as academics, in translating our research to making a difference out there. We're beginning to pick up the theme from all the speakers. Like, we have a responsibility. We have a responsibility as academics to change the lives of the people. Thank you. Over to...
Thank you, Daphne, and thank you, Prof. I'm going to introduce our next speaker, Prof. Salome Maswime, the head of global surgery at the University of Cape Town. She's a professor and the head of global surgery at the University of Cape Town. an obstetrician and gynecologist, and the president of the South African Clinician Scientist Society. She was the Discovery MGH Research Fellow in 2018 at the Massachusetts General Hospital and Harvard Medical School, and a former lecturer at the Wits University. Salome is from Limpopo Province, South Africa, and after qualifying as a medical doctor at the University of KwaZulu-Natal, she completed her fellowship and master's in medicine degree in obstetrics and gynecology, and she also has a PhD in obstetrics and gynecology. She's worked in various hospitals in the country, including Chris Hani Baragwanath here in Soweto for about 10 years. She's recognized as a global surgery expert in surgical and maternal care. She's an advisor and consultant to several institutions, including the World Health Organization. She has received numerous awards for her tenacity and commitment to maternal health and for ongoing research in maternal health. Welcome, Prof.
Thank you so much. I'll wait for my slides. Okay. I don't have a screen. I don't have a screen. Greetings and thank you so much. It's such a great honor to be here, all the way from Cape Town. I know many have traveled from much further, but it's really exciting to be here. But also as a Witsi, as someone who discovered public health in this department, I say I'm an obstetrician and gynecologist with a special interest in public health. I accidentally found public health doing my PhD on cesarean section outcomes. At the time, I imagined that I was going to discover a new technique in theater, and all my data pointed to the School of Public Health. So I accidentally ended up here, but it's an accident that I'm very proud of and very happy to have ended up in this place. Let me acknowledge the Vice Chancellors, the Head of School, Assistant Dean, Prof. Crisp, all the speakers, organizers, colleagues, friends, guests. Thank you so much for having me here. And I'll just start off by saying the future will have to be different if we want Africans to live longer and to fulfill their human potential. We have to start by thinking about healthcare in Africa, by thinking about our mothers, our fathers, our sisters, our cousins, our friends, our grandparents, and those who will come after us. So I've put a few quotable quotes. This is my journey on how I discovered public health and how I discovered systems and the thoughts that went through my head. So the first one was this line that says, diseases don't have borders, but health systems do. And understanding that even though how we treat diseases might be pretty consistent across the world, how we operate and look after patients is quite similar, but how health systems function is very different. And that's why if you move across provinces or move across countries, the health outcomes will be very different. The second one was that as clinicians, we are only as good as our health system. It took me many, many years to discover that, because when patients were dying in my hands, I thought the problem was with me. And so I kept studying and studying and studying until I finished my PhD and realized maybe the problem isn't me. Not that I regret doing the PhD, but that's where I realized that there was something much bigger which was determining my outcomes. And that's how I moved into this world of trying to understand systems. Some of you would have seen this quote recently in an article in the Daily Maverick. These were my words. No one taught me how to treat a sick health system. And just like patients, we taught as healthcare workers to look after sick patients, to heal the patient, but who heals the health, a sick health system, and who prepares you how to look after a sick health system. So this was my first shot at trying to write a public health paper in obstetrics and gynae, and I wrote it with a former MPH student from here, and our title was Increasing Caesarean Sections in Africa to sell more cesarean sections as we do as obstetricians. But what I was trying to say is that in just around the continent, there is an unmet need for cesarean sections, but because the media speaks about overuse of cesarean sections, even when we talk about our own problems as Africans, people don't believe us because they don't relate to what we are saying. But what was more important was after putting this all out, and for the first time, you know, as an academic, you publish, one or two people will read your paper if you're lucky, beyond the abstract. But now, because this was in the conversation, for the first time in my life, 24,000 people had read my paper. So I felt really famous for a moment, which is what happens. And that's where I kind of learned that there needs to be some sort of advocacy that goes along with the research that we do and what we put out there. But then after that, then we published a paper in the Lancet, also probably not read by many people, where we published that African women were 50 times more likely to die from cesarean section complications than women in high-income countries. This is work that we had done. I was the lead obstetrician on that study. And so after telling the world that let's increase the number of cesarean sections, my data said something else completely different and told us how dangerous it was to do that. I'll come back to that shortly. So as I said, obstetrician and gynecologist with a very special interest in public health. I'm a head of the Global Surgery Division, which we have now discovered what we call surgical systems. I don't know how public health specialists feel about that, but that's what we say we do. But I'm also the chair of the Health Systems Trust Board, which I think is my only proper claim to fame in public health. And as you can see, a lot of my work was clinical, working in the labor ward, looking after sick patients. Then I went into what we call community obstetrics, going out in the clinics, trying to equip and strengthen the health system or the clinical system from that perspective. And then I discovered problems were across the world and not just in the local clinics and outside our region. So you may know these stats, these numbers. 500,000 people in Africa lack access to healthcare. But that's not bad. Half of the continent is getting access to healthcare. They'll find a hospital, they'll get inside. But when you start having more complex conditions that require surgery, over 90% of the continent cannot have access to safe and timely surgery. So simply putting hospitals across and creating a space for people to come in doesn't mean that people are going to get the care that they need. And unfortunately, a lot of people lose their lives even inside of their healthcare systems. So why are women in Africa dying from cesarean section complications? And perhaps why are people in Africa dying from healthcare complications and conditions? It's lack of access to care. It's delayed access to care. You're in the system, you've recognized that you're sick, the ambulance cannot get you there on time, but you're in a hospital, they've recognized your condition, there are no specialists, there's no multidisciplinary team, there's no one who knows how to look after the condition that you've got. And if you are a junior doctor who's worked in a rural hospital like me, where you feel completely helpless because now you kind of know what to do, but you don't have the resources, you don't have the blood, you're waiting for hours and hours. Patients will die in your hands, but you won't know what to do, and often you'll think that you were the problem. And of course, shortage of equipment, resources, infrastructure, poor rehabilitation, and understanding the whole pathway. So even we did this study now. I mean, a lot of my work was to describe the problems, as I said. And now we felt that now that we know the problem, and I think that's where the lack or the mismatch is in public health research. We describe what the problem is. We want to understand it so that we can intervene, but very few studies are actually intervention studies that tell us what works. And so we conducted a Delphi trying to understand what we could do. And this was obstetricians and anesthetists that were asked these questions, and they gave us public health answers, that it's community health promotion, health education. So what I'm trying to say to you is the rest of us as medics are now interested in health systems and are starting to do our own health systems type research. But we're not sure if we're doing it correctly because we didn't really study to do this. We are learning as we go. And that's a big opportunity, I think, for the public health discipline. And so my key message today is that we need to move from services to systems. Of course, what you look at and what people like me are now looking at is strengthening systems. But these systems have to be so that service delivery improves. So there is a real gap between services and systems, and that is the gap that we need to fill if we want to improve the future of research in Africa. I use this example of obstetric transition because it looks at maternal mortality rates by country, it looks at a health system, and the interventions it develops is very specific to each health system and each country. And perhaps we shouldn't choose a one-size-fits-all. We need to spend more time understanding each health system individually so that the interventions we come up with are also specific to that. So what is the aim and nature of public health research? It aims to elucidate the factors that determine the health of a population. It's multidisciplinary, and again, we cannot run away from the fact that after COVID, all of us are talking about systems. Everyone is interested in systems and how we can strengthen systems. It's no longer just the domain of public health, and we need to now integrate and say, how are we going to work with multiple disciplines so that the outputs and the evidence that they find also feeds better into. So I'd like to propose that my registrars can also come to you from the surgical disciplines and not just the public health registrars. So the other important part is studying the status of the population health, and I think a lot of that has been done well. But at some point, you have to move beyond describing and intervening and developing and assessing innovations and interventions that will improve efficiency and effectiveness and the organization of our healthcare services. And I think that's the biggest opportunity that we have for the future. When I said no one taught me how to treat a sick health system, that's what we need to learn how to do. And I think you can all help us in going there. We are all quite familiar with the social determinants of health and the economic. I've touched on the geographic as you look across the world and see the differences across health systems. The biologic we're quite familiar with because that's what we do as clinicians. But the political is also something that we don't often talk about, the political determinants of health. And as you can see, I'm not looking at Professor Crisp right now because for obvious reasons. But we have to hold our governments accountable because the policies that they put in place will determine as well what kind of resources go into our healthcare systems, what type of investments go into it, and how ultimately we will get better patient healthcare outcomes. Quite proud of the work, this work that I've done. Recently, we published the South African Health Review through the Health Systems Trust, and that again is a way of collating information so that it's accessible to the rest of the world and the nation. A lot of the work that we do is so disjointed across universities, but when we start collating it and organizing research so that it's accessible, then decisions are made for a collective. But the other thing that we did with my team was developing a research strategy for global surgery. And as I said, this is a new discipline in medicine, about 10 years old now, and us trying to understand what are surgical systems, this interface between clinical disciplines and public health, and looking at leadership. What is our research framework? And that's what we did. So what are the present challenges with the public health research agenda? I think the most important one is who is setting the research agenda. And there are many complexities to this question, because often as academics, we set our own research agenda. If you ask me what research I want to do, I will choose cesarean sections because that is my interest. Whether your country has got good or bad cesarean section outcomes, that's what I'm doing because that's my niche, and I'm not moving away from that. But that doesn't help a country that has got other problems. And often you find that researchers come from outside with their own agendas, with their own interests, and that sets the agenda. And yet people have got other conditions that perhaps are more important. Who is doing the research? That is very important. Who is funding the agenda? And I'm going to talk a bit about that shortly, but the reality is that many of us follow the money. I think when I realized how much funding there is in HIV, I also added an HIV cesarean section with HIV and stillbirths. You start following the money so you can get the grants, but that's not how research is supposed to do. And then who's not included in our research agenda, I think is even more important. So many diseases that are there, and yet we keep sticking to the same groups of diseases. And then where is the regional collaboration? It can't be South Africa working alone. If we want to improve Africa, we need to have a global view and look across the continent and partner and collaborate with each other. So research agendas are often not aligned with the burden of disease. I took this graphic, I think from the Lancet, looking at the tallies between 1990 and 2019. And yes, there has been a shift of priorities, but has there been a shift in the research agenda? If ischemic heart disease is the condition that is killing most people, is money going there? Is it at the top of the public health agenda? How many of us in this room are actually doing research on stroke, on ischemic heart disease, non-communicable diseases? Are we all sticking to very similar type of conditions? And, okay, let's try this. Okay, it's not working. Okay. Is it okay now? Okay, cool, thank you. All right, and then as I said, research shouldn't follow the money. You've got HIV, TB, AIDS, malaria, over $4 billion US invested in that. Injuries which are at the core of many deaths in Africa across the continent, whether it's borders, cars, narrow roads, that's not getting as much investment. And in my field, you look at surgical diseases, and no one wants to fund the research that we do. So if there are any funders, we are looking for some funding. So what are the opportunities for the future of research in public health? One, strengthening multidisciplinary collaborations and research across disciplines with the highest burden of disease, looking at emergency medicine, looking at surgical diseases, non-communicable diseases, those diseases that we don't often hear about in public health conferences. There are opportunities for system-focused intervention trials. You know, yes, we can do the pharmacological, but I think it's time we start designing and piloting interventions that are system-focused. How do we strengthen a system? Because ultimately that is what we want to do. And then looking at the burden of disease within the local context and determining the research agenda based on that. I'll remind you that despite the advances in healthcare, we have the highest burden of disease in Africa. We have the lowest life expectancy. So there is a definite need for local and African and regional collaboration. And we need to start putting our minds together, because these people that are dying, it's us, it's our family members, it's our relatives. It's not an us and them, it is us. on the continent. So we have a responsibility to commit towards improving healthcare. I want to predict that a future Nobel Prize will go to whoever unlocks access to healthcare, because that is the greatest challenge of our generation. We've gone through understanding, defining new diseases, defining new disciplines, discovering new drugs, discovering new equipment, etc. But our people still do not have access to healthcare. So whoever is going to unlock that in the future, I think is really going to take medicine and public health forward. We need to unlock health system strengthening. It's not just about describing what do we do, what works, how can we treat that sick health system, and remembering that everyone has a right to benefit from advances in scientific progress. We need to always remember that, because if we all know how to treat a woman with preeclampsia, why are women dying from preeclampsia across the continent? If cervical cancer is preventable and treatable, why is it the leading cause of death on the African continent? So I'll close off by saying that the future of public health research is bridging the gap between health services and health systems. Thank you very much.
Thank you very much, Prof. Your talk actually highlighted how all roads actually lead to public health, even in clinical practice. And I hope it actually serves as a clarion call to all health practitioners that you need to see the community member, the patient that you're seeing in the larger context that they exist in. So thank you very much.
Thank you for bearing with us. We are almost at the end of the session, but we asked few people to kind of like, we've listened to a number of speakers to give us just take-home messages from the speakers. It's gonna be Dr. Evelyn first. I'm gonna walk over with the mic to her, and then followed by Prof. Risper, then our Prof. Steve Tolman. Thank you.
Thank you, Daphne, and thank you, everyone. And it's been such a great session. I don't even know where to start. You know, Prof. Salome left us with that point that despite advances we have made, we have the greatest burden of disease and the lowest life expectancy. And then we started off this morning by being reminded that if we can't answer the so what of what we're doing, then we really shouldn't be here. So, you know, that's a point that we have to think about. And then Catherine brought a daunting thought to us about roads and what about roads. And everything that we've talked about today leads to the point that if we do not work in interconnected ways, roads is always going to end up in that kind of outcome. So we need to think about that. And then the point of translation and the point of how we share our data and our evidence so that I don't know if I should call him a politician, can use it and make changes that we need to make so that the health system works. These are things that we need to do. And ultimately, it is actually the thing that will make us the research leaders that Catherine talked about. We're all leaders in this room, but the only way we will be recognized as leaders is if the evidence that we're generating gets into the hands of the people who can make the changes. So we need to think about all these points that have been raised and to challenge ourselves and remind ourselves every morning as we wake up as leaders, is it going to make the change so that Rose can thrive and survive in a world that there's equity? Thank you.
Thank you.
Thank you very much. So I took Daphne's instruction yesterday afternoon quite literally. And so I have 5 key messages from the presentations this morning. And then I want to be a devil's advocate and just kind of raise what I thought as a deafening silence on the part of all the speakers, if you may. So the first message was around a value, the role and contribution of the academy and making a difference. And that almost was a cross-cutter that came from all the speakers. The second message was focused on the social, commercial, and political determinants of health. And as Dr. Catherine talked about the story of Rose, some of the things that went through my mind was the issue around gender equality as one of the three, as one of the goals of the Sustainable Development Goal. But she also raised critical questions around thinking around population growth, space, and of course, both Linda Lani as well as Catherine raised issues around the environment and environmental health. The third theme or take-home message that came through for me was what I called health, well-being, and resilient health systems. And both Prof. Maswime as well as Prof. Nguni talked about the burden of disease and having a holistic approach to that. The role of technology in solving complex problems, and of course the problem of resource constraints of health systems in Africa. But one of the things that I thought that the story of Rose brought to me was that the failure of health systems is most acutely felt by poor people. And the face of that poverty often is women, Black African women. And I think we need to remember that. The fourth major cross-cutter or theme that came from all the speeches or all the talks was what I called research capacity building and translating evidence or research into practice and sustainable changes. And I think it was Tobias that talked about that increasingly we're seeing the shift of both power and center of knowledge production to Africa, which is good, but also brings its unique challenges. So Africa presents unique and major opportunities that we have to grab onto, but for that we need a range of skills. So yes, we need the hard skills of research, how to do good research, so that people don't question the kind of reproducibility or generalizability, but also the softer skills of listening. And of course, we have to keep on questioning. We have to rethink, particularly how technology might change our approaches. And then, of course, a big issue around research, particularly translating research or evidence into practice, is always the question of behavioral changes. Nicholas talked about compliance, or rather non-compliance, and he raised the interesting concept of research practice partnerships. So my challenge to you, Nicholas, is that what you were describing, I like the idea very much of research practice partnerships, but I think we need to be careful that we don't create a purely medical model of those research practice partnerships. And what you were talking about in regard to public health medicine registrars, there's a potential danger that it becomes very much a medical model. And I would suggest that we look at a multidisciplinary model, and I want to thank you for certainly making that a possibility. The last issue the last theme is what I called leadership and community engagement and participation. And we were reminded that we should all recognize our privilege of sitting in this audience, our privilege of education, and our privilege as researchers, and that we actually the leaders and need to recognize our capacity to exercise leadership. But we have to listen to communities, and particularly we have to listen to women. Or maybe it's just a message that I wanted to hear. But I think important issues around that theme of leadership and community participation and engagement is also the need for a broader systems approach, and then of course the importance of collaboration and networks. So those are my key take-home messages, Daphne. But what I wanted to just, if you may, I want to be devil's advocate and just highlight the things I didn't hear from any of the speakers. The first one was around climate change. Very few of you actually talked about that. Yet the very fact that we're actually wearing thick, heavy coats on this 14th day of September is an indication of these changing weather patterns and how climate change actually is going to get worse and be exacerbated. The second issue that nobody talked about, I thought, I looked at Salome's slide when she highlighted the burden of disease, but nobody said anything about mental health and mental conditions, and that's going to be the #1 condition by 2030 that all of us have to grapple with. And it comes also with all those other issues around stigma and discrimination that where people often don't seek care, and where our health systems or our health professionals are unable to deal with mental health. Nicholas, again, if you may, a challenge to you is you talk about people being resistant to change, and we need to get mid-level managers to embrace research. But I would say we also need to get politicians and executive managers to embrace evidence and research, and to actually consider that as part of their armament of making decisions. And the last one is just around the importance of a capable public service and government stewardship to achieve some of the things that we highlighted here today. But thank you very much for the opportunity.
Thank you, Daphne. Thank you, Letitia. Thank you, Evelyn. It's been an extraordinary privilege to sit and listen to outstanding colleagues sharing their insights, their thoughts, and in some ways the pain, the emotion, the possibilities, and the opportunities. I'm not as well structured as anyone else who's spoken today, but I think I also have 5 elements, Daphne, that I'll touch on. The first is just what we heard. Who is Roz? If not me, who? Research, practice, and behavior. The future will have to be different. I don't think I'm making it up that without fail, every person who spoke today talked about local context and trying to understand the lived reality, the lived environment. You know, we often say local and global context. The global will take care of itself, believe me. The local context really can inform and stimulate and challenge and inspire. I do think there was engagement with interfaces between research, education, and training, and what multidisciplinarity or interdisciplinarity or transdisciplinarity might mean, and also how that interface extends to practice and, where we can, to impact. And forgive my not remembering who it was who said, I don't know how to measure impact. Well, many of us don't, frankly. But what is impact? And what does it mean? And how does it express itself? It's possible that in that transition from the research, training, practice, impact, there is a return loop. And the return loop comes back to the reflection, the thinking, the African Academy. Who is the African Academy? Guaranteed, the Academy's in this room. This is the African Academy. This is that community that brings practice into science, into activism, into academia, and the multiple hats, citizen hats, that we all where. And this gathering of colleagues, younger and older, all on paths towards more and greater contributions, but under the umbrella of schools and faculties in public health, CARTA consortium. This really is the African Academy. We're looking at it, we're experiencing it, we're feeling it. And these are the colleagues, as I see it. We need to go together. The achievements are there, and we can make progress and the headway in our lifetimes. And I thought to end, Daphne, with a quote. It was the early speakers who reminded me of a quotation by the anthropologist, the late Margaret Mead. Never doubt that a small group of committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you.